I do is I basically try and fix blood vessels of the head and neck, depending on what pathology there is. So what I'm going to try and go through and tell you guys is what the causes of stroke are, what some of the risk factors associated with stroke are, go through a couple cases to demonstrate what types of strokes there are, and try and educate everyone. And then in addition, see some cool pictures and see what we do on the fly, at least what I see, and I'll try and describe it in layman's terms of what it is we're doing and how to fix or not fix certain things that we see. So with all that said, I'll get started. I am a neurointerventional radiologist, and what that basically means is I fix blood vessels of the head and neck by going through the groin. And when you tell the average layperson that, they're like, going through the groin, what are you doing? You're crazy. It's basically what a cardiologist does for the heart, I do for the head and neck vessels. So as they open up the head and neck vessels, as they open up the heart vessels, I basically open up the head and neck vessels and fix a lot of different things that are not seen in coronary arteries that the cardiologists do, but are seen in the head vessels. So we'll get started. And you'll see a bunch of pictures through this whole presentation. Some of them are from San Francisco, where I did some of my training at. And this is a picture of Lake Tahoe and Emerald Bay when I used to live out there. Some of the facts about stroke are there's about 800,000 Americans each year suffer a stroke. And that means on average about one happens every 40 seconds. Stroke kills, and I'll let you guys handle the lights. A stroke kills about 137,000 people a year, and that's 1 out of every 18 deaths. And it's the number 4 cause of death. About 40% of stroke deaths occur in males and 60% in females. So technically, even though more males suffer strokes, more females suffer death from strokes. In other words, the mortality associated with strokes is higher in females, but it happens more in males. The 2006 death rates per 100,000 population were 41% for white males and 41% for white females, 67% for black males, and 57% for black females. So it goes with the numbers that females suffer less strokes, but usually the effects of the strokes are more devastating in females than they are in males. And the cost is about $73.7 billion in 2010. That's with regards to hospital costs, disability associated with time off for your job. And the penguins up there, just to say, wow, this is pretty impressive that stroke is this high on the list. What we're here to do today, most importantly, is describe what the symptoms of stroke are and help you guys recognize what a stroke is. So if you are having a stroke, or a loved one is having a stroke, or someone that you know is having a stroke and they're saying, hey, I can't move my arm as it used to be, and it's been going on for the last half an hour or 40 minutes and it's just dragging, say, hey, that could be a stroke. Why don't you get that checked out? You know, instead of sitting on it and waiting till the next morning thinking it just might get better, and it doesn't get better, and therefore they're out of the window for anything to be treated. And why that's important is because some of the strokes that come in can be treated within 3 hours or up to even 4.5 hours with a drug that is a clot-busting drug that they just give through the arm called tissue plasminogen activator, or TPA. So it's time sensitive. If you get to the hospital within 4.5 hours, then of course you can actually be treated with certain patients if you are having a certain type of stroke. The other thing is, if you get to the hospital within 8 hours and you don't qualify for the clot-busting drug, you can actually qualify with what I do, which is go up and try and grab the clot out of the head vessel and resolve the clot. But my cases are usually resolved for those patients that are failing the clot-busting drug or that are outside the window. The best cases that we can treat are those cases that what Dr. Decker does is infuse the clot-busting drug and open up the head vessels without any intervention. So basically the signs of stroke, the American Heart Association has the mnemonic FAST, and that is if you are suffering from weakness of the face, weakness of the arms, having speech difficulty, then it's really important to recognize those symptoms, and if they persist for greater than half an hour, then it could be the signs of a stroke, and time is our friend. So if we try and get you in, or you try and get yourself in within a reasonable amount of time, we can actually get you treated in the appropriate fashion. Certain hospitals in the Bay Area are comprehensive stroke centers, and when they say comprehensive stroke centers, they're certified by the ACA, which is a group that certifies programs in hospitals to treat those patients that are having strokes. The reason why it's important to get to one of those hospitals is because we provide those services that can treat those patients within a timely fashion, and we have the expertise to back it up, to say, hey, these patients are treated in this specific way. So numbness or weakness of the face, speech difficulty, arms or legs, those symptoms could be a stroke. Mnemonic is fast, face, arms, speech, or time, and actually arms or legs or the entire side of the body. That's really important to recognize those symptoms and to actually bring yourself to the hospital, not drive yourself, but call 911 and get yourself to the hospital as soon as possible. The risk factors associated with stroke include hypertension, and I broke them down into kind of those things that you can actually change and things that you can't change. The things that you can change, if you have high blood pressure, you can make sure your blood pressure is potentially less than 130 to 140 systolic, either by medications or your diet. Diet is a really strong indicator of driving hypertension. If you look at the vast majority of things that you go to the supermarket, canned foods are loaded with salt. I myself am hypertensive, so I have to watch what I eat all the time, and I try and keep below 1,500 milligrams of salt per day. And by doing that, I keep my pressure at bay, and I'm pretty much good. I do take medication, but at the same time, if I go out and have McDonald's or any other fast food, and you don't understand what you're eating, they're loaded with salt just for the main reason that it's a big preservative that everyone uses. So hypertension is something that can be controlled either by medications, seeing your doctor with medications, and exercise and salt intake. Tobacco use, it speaks for itself. Tobacco does increase the risk of stroke. It increases the risk of lung cancer. So therefore, removing the tobacco use out of your lifestyle improves your risk factors. Diabetes, same thing, can be controlled by diet, exercise, and medicines. High cholesterol, some people have high cholesterol, other people don't. Some people are lucky, others are not. Cholesterol can be also, some people cannot change their cholesterol. If they have high cholesterol, no matter what they do, it doesn't bring it down. Other people, it is dependent on your intake of food, and your medicine that you take can actually bring your cholesterol down, as well as exercise, which leads into inactivity and obesity. The more inactive you are, the more chance of having high blood pressure, the more chance of having diabetes, the more chance of having high cholesterol. So activity, whether or not you walk a little bit a day or whether or not you don't walk at all, usually the more you walk and the more you exercise, the less chance of having a stroke, or the better chance of preventing a stroke in the future. My dad walks 5 miles a day, and he's 84 years old, and if it wasn't for him walking 5 miles a day, he'd probably be dead right now. So the fact that he's walking, we encourage that as much as we can. Excessive alcohol intake, it's usually more than 2 drinks a day that'll do it. And certain illegal drugs such as cocaine, cocaine, what it does is it causes the vessels in your head to constrict. It also causes, over chronic time, the vessels in your head and small vessels to get narrowed, being that the lining gets thickened, and therefore you cannot use those vessels anymore. Other things that you can't change: gender, of course, we're either female or male. Age, as you age, you have an increased risk of having a stroke. Certain blood disorders, such as sickle cell anemia, have a higher risk of stroke, and other people that are hypercoagulable with certain protein deficiencies that are inherently built in their body have higher risk of stroke. And race, as we described before, patients that are African American usually have a higher risk of stroke. What I saw in San Francisco was patients that are from Pacific Rim that are on an American diet, such as being from Hawaii, that there's a lot of American influence in Hawaii, have a higher risk of having stroke than patients that are from the Asian Rim, but are staying on a non-American diet. So race, unfortunately, you can't change, but diet you can. The different types of stroke, they're broken down into 2 separate categories. You have a chance of one type of stroke is what we call an ischemic stroke. In other words, you're not getting enough blood supply to a certain part of your brain, either from a part of your brain being, one of those vessels of your head and neck being blocked, as in this case where you see a clot sitting in a vessel blocking the brain and causing the stroke, or you can have a vessel that's narrowed or stenotic, where the vessel is giving some supply to the brain but not as much as the brain requires. And that narrowing can be either caused from a narrowing of a neck vessel or a narrowing of a head vessel. Most commonly, patients have narrowing of a neck vessel. That's why you hear the term carotid stenosis. And carotid stenosis can cause a stroke. It usually has to be a certain percentage, but I've seen it where it is not. And then you can also have vessels in your head being narrowed, and that's why I spoke of some of the patients in San Francisco that were on an American diet that had more vessels of their head being narrowed. And then the other thing is you can have a clot that goes from your heart and gets sent up to a head vessel and blocks that head vessel and cause a narrowing. So essentially, when it comes to ischemic stroke or stroke that is from not enough blood supply to the brain, it's usually from a vessel being narrowed or a vessel being occluded. And if it's from a vessel being occluded, that is something that either the clot busting drug that I talked about earlier, if you get it within the hospital in a certain amount of time, that clot busting drug can fix. Or if you don't get it within a certain period of time, within that 3.5 to 4 hour window, but you're within that 8 hour window, that's when they ask me to go up to the head vessels and try and take the clot out. So the next type of stroke is it's called a hemorrhagic stroke. So there's ischemic stroke, not enough blood supply to the brain, and then there's hemorrhagic stroke. In other words, you've bled inside your brain, and usually the bleed inside the brain is caused from some type of vessel that's irregular. In this case, it's what they call an aneurysm, which is an outpouching of a normal vessel or a weakened part of the vessel wall that becomes weakened to the extent that the vessel ruptures. In other words, if you imagine a balloon, a small balloon that you blow up, that small balloon initially is very hard to blow up because it's small, but as physics takes over and the balloon expands, it gets easier to blow up because of the physics associated with the strength of that wall as the vessel expands. Same thing with the blood vessel in the head. As this thing enlarges, it gets easier and easier to blow up, and eventually when it ruptures, it'll either rupture into the brain tissue itself, or it may rupture into the vessels surrounding the brain. And when that happens, they ask me to come in to do an angiogram, which is looking at the vessels of the head by going through the groin to see what the cause of that bleed is. And I'll go through those to show you guys what it is. But basically, you can have an ischemic stroke, like I talked before, not enough blood supply to the brain, or you can have a hemorrhagic stroke where there's a cause of a blood vessel being weakened from an aneurysm, which is the outpouching of a normal vessel, or other things called an abnormal tangle of vessels in the head, called an AVM, and stuff like that. Other causes of stroke, which is a hypertensive stroke, where if your blood pressure is chronically high, you can have a bleed inside the brain from a small vessel in the head that is usually from a hemorrhage or from a hypertensive. And then you have iatrogenic, which is caused by either someone giving someone a blood thinner too much, like if a patient's on Coumadin and their blood thinning capability is too high, they can bleed inside the brain. And then idiopathic, where we didn't know the cause of the bleed, we just assumed it's from something that is a vein that we can't fix anyways. So essentially, types of stroke: not getting enough blood supply to the brain, which is ischemic; hemorrhagic, which is from a vessel being dysplastic or irregular and bleeding inside the brain or surrounding the brain. And we're going to go through these to show what we can do for those certain things. So I'm going to show a bunch of cases, which are a bunch of pictures. I'm just going to go through some cases. The thing that's really important is for people to know the right side of the brain supplies the left side of the body. The left side of the brain supplies the right side of the body. Just think the opposite side of the body controls the other side of the brain. The reason why I'm going through that is because as I describe some of these symptoms, I'm going to say this person has right-sided weakness, and you're going to look at the images and say, wow, that's on the opposite side of the brain. What are you doing? You don't know what you're talking about. So opposite side of the body supplies the other side of the other side of the brain supplies the opposite side of the body. So basically, 63-year-old gentleman had what we call dysarthria, which is inability to speak, or not inability to speak, but mumbling his speech, and left-sided weakness. So right then and there, you're thinking to yourself, well, maybe it's left-sided weakness, right side of the brain, opposite side of the brain controls the body. What we first do is we first do all these imaging, MR, CT, to figure out what's going on with the brain. A stroke on an MRI looks like a light bulb. So that basically is a light bulb. Abnormal, abnormal. And these are different slices of the brain cutting through the brain like this. So we see a very large stroke on the right side of the brain, which goes along with left-sided weakness. And then there's small little strokes on the left side of the brain. Okay, well, we can't figure out what's going on here, but we'll do an MRI or an angiogram. MRI will look at the brain vessels as well, and an angiogram will look in detail about the more brain vessels, and we can see what's going on. So the MRA, which is an MRI machine, but it's looking at the vessels. MRI looks at the brain tissue, MRA looks at the vessels. And what it stands for is MR angiography and MR imaging. So MRA is looking at the blood vessels, and you can see that if we look at the brain, everything should be symmetric. So everything here should also be on the other side. So there's no vessels on the right side of the brain, which is telling you, wow, no vessels on the right side of the brain. He's got a big stroke on the right side. Why is that the cause? And the cause is actually the right side neck vessel is occluded here, which I'll show you in an angiogram, which is, this is an MR angiogram, and the left side is really narrowed in the neck. So on the right side, when they asked me to do the angiogram, there's the occlusion. This vessel should go up to the head. And in the head, when I looked at the head vessel, there's nothing there. And then later on, it fills in, but it fills in through collaterals. And then on the left side, you can see this vessel comes up, it splits into the face vessel, and then it splits up into the head vessel and goes up to the head. That's highly narrowed. It should look like this all the way down to here. So right side was out. He was already way out of the window to treat the right side. And the left side had a high-grade stenosis. So the rule is if there's a narrowing, you can usually open up a narrowing at any time. It's always better to do it earlier than later. But if it's shut down, there's the time window that you have. So the right side was shut down. The left side had this narrowing. So I was asked to put a stent in the carotid, which is looks like chicken wire rolled up. One loop of chicken wire, like a cylinder, that's what a stent looks like. The reason why stents are important is as you place a stent, it opens up the vessel and it keeps the vessel open like chicken wire does, rolled up. So what I did is from the groin, I put a wire up past this narrowing, and these are all the same pictures except without any dye that I'm using, with dye, and then this is the same picture except I subtract it out or take it off all the bones so all you see are the vessels. And so I put this little wire up, and it has a little net like an umbrella so I can drive a stent over this and open up this vessel. So what I did is I landed this stent right here. You can see it looks like chicken wire in this vessel, and you can see that this is what it looks like at the end. And then what I did is I gave you guys a comparison, so before and after. And you're going to say, well, it doesn't look as much as it should, but trust me, that's pretty open. And then this is the exact filter. This little loop here is this thing, which is the same thing as this thing, except this is the manufacturer's images, and this is the actual patient's. This is that one that I pulled out of the patient at the end of the case, and you can see that it's a little bit yellow here. That was all clot that I used, that when I put the stent down, all this debris here gets caught by this filter and doesn't allow us, the stuff to go up to the head vessel because the direction of flow is up. So as you're putting the stent in, it can actually shower clot up to the head, which you don't want because that can cause worse of a stroke than he already has. So in this case, the patient did really well. And then the other things I talk about, and the other cases that I have are cases where the vessels are either occluded or narrowed inside the head. So going all the way from the groin up to the head to try and open something up to either prevent a stroke or reverse a stroke that's happening. And the things that we have in our repertoire to treat stuff are either going up there directly into the vessel that is occluded and either injecting a drug that's a clot-busting drug, which is called intraarterial thrombolysis. Thrombolysis means lysing the clot. Thrombo means clot, lysis means lyse it, and intraarterial is going right inside the vessel. And those are only used in those cases where if they go through the vein and they try and open, and they give you the clot-busting drug that it doesn't work. The other thing are what we call mechanical thrombectomy. We're actually going up there and mechanically trying to either remove the clot, aspirate the clot, or break the clot apart. So that's why they call it mechanical, is you're actually mechanically opening up the clot. And I'll show you cases of each of these as well. So this is a 60-year-old female that had right-sided weakness. So we assumed that it's a left-sided brain abnormality. They asked me to do the angiogram and try and see if I could lyse the clot. And this was a case, and you can tell the pictures aren't the greatest because she was actually awake when we were doing it. And in addition, it was before we had all the newest, latest and greatest tools that we have now to remove clot outside the body. So this is a pretty old slide. But anyways, this vessel should go up here like this, and you should also see vessels along here. So these are the same images, just side by side. One's looking from the front and the other one's looking from the side. This vessel is occluded, and this is the same vessel occluded in a different plane. So I went up there with a small little tube called a catheter and got up into that head vessel and infused the drug, which is called TPA, into that vessel. And at the end, you can see that the vessel opened up. And sometimes it works, and sometimes it doesn't. Whoops, sorry. So before, this vessel was not open, and now it is, and this vessel was not open, and now it is. There's video feedback. As I'm doing the images, I can keep the machine running to see stuff going in real time. So as I'm injecting the dye, I can actually see it go up to the head vessels like a movie. And I'm actually have another pedal that I can see as I'm working. I can see the stuff moving live. So it's like Nintendo, if you want to. It's very live. I'm not saying we're playing Nintendo with patients, but imagine it's real time what you're doing. Very real time. What the ultrasound does is, for this patient, I'll show you. What the ultrasound will be able to do is non-invasively and a lot less expensive than a high-end procedure like this. It's a good screener. In other words, it will basically be able to tell you if there's an abnormality that you need to follow up with anything else. It'll be able to say, within a range of 20%, how narrowed that vessel is. So in this case, in this patient, they would have done this ultrasound before he had the stroke, and they would have more than likely showed that this was at least 90% narrowed, so they would have given him a range of greater than 80%. And they would have probably said the other side, which was the occluded side, which was this, was either 100% narrowed or like 99% narrowed. So before he had his stroke, they would have been able to say, you're at a high risk for having a stroke. You need to have the right side fixed, and then you're going to probably need the left side fixed as well. So it would have been able to point him in the direction of getting treated before he would have had his stroke, which is very important because then he wouldn't have had his big stroke. Because I can tell you, that's a big stroke. That's a very large stroke. You can actually see it occupies about a third of the whole brain tissue itself. So yeah, ultrasound will definitely help screen, and that's why they call it screening, is because it will be able to tell you how much narrowed those carotids are and are you at risk for having a stroke. Because if you are and it's greater than 70% or 80%, actually Medicare says 80%, some people say 70%, but if it's greater than 80% and you're not symptomatic, you would do better having it fixed than not having it fixed. And when I say fixed, the vast majority of times the gold standard is fixing it by having an endarterectomy, where they open up the neck, clean out the vessel, and close it up. But some patients are better candidates of having carotid stenting, although that is not the carotid stenting, which is what I just showed you, is not the gold standard unless you have a contraindication. Like he had a contraindication which the other side was occluded. Or certain patients can't undergo general anesthesia, so we just do it. That is why we try and treat as soon as possible, because what we try and do, look on imaging to see what, and I have a slide of it, what tissue is at risk and what tissue is damaged. The tissue that's damaged usually is gone. You can't do anything about it, but the tissue that's at risk, you can usually salvage. So what you're trying to do is you're always trying to find a balance. Like in his case, this is on the left side, so technically the entire left side of the brain is at risk. Not the entire left side, but the vast majority of this side is at risk. This is already dead. There was nothing for us to do on that side. But on the opposite side, that was all salvageable tissue, and that's the reason why we stented him, because we didn't want him to have another stroke on the opposite side and be really bad off. So yeah, that's what we try and always do, is try and figure out clinically, from a standpoint of imaging, what vessels are at risk and what vessels are not at risk. Or what tissue is at risk and not tissue. But once the tissue's dead, it's kind of mute to try and open anything else up. So we went through this one, and in this case, technically the entire left side or the territory of this vessel was at risk. How much was damaged at that time, we didn't know, because at that time when I did this case was 2000, and we didn't have the imaging that we have now, where you can do a CT scan that shows you how much tissue is at risk and how much tissue is dead. We just had to assume what's dead on the CT is dead. We didn't have the capabilities as we do today. So, right now we have extremely great capabilities at this hospital, and all the Florida hospitals have them. They've got some of the best imaging out there. So the other device that we use is a thing called penumbra that's basically like a tube and a vacuum. You have a tube that hooks up to a modified vacuum that tries to suck out the clot in the head vessels. This case is a 75-year-old gentleman, right-sided weakness, that's the hemiplegia, that didn't improve. And this gets to your question with what tissue is at risk and what tissue is not at risk. This is the study that I was talking about that is the most advanced stuff out there right now. It's called the CT perfusion. In other words, it's a CT scan of the head, but it actually looks at the viable tissue and the non-viable tissue. This red is bad, this green is tissue at risk. So red side is dead tissue, but see how much that's still viable, that if we save within a certain period of time, they won't go on to a stroke. That's over half this amount, so we decided to try and open up that vessel. And this is a non-invasive way of looking at the head vessels, where they got images of the head vessels with the contrast they used when they injected the arm. It almost looks like someone actually just cut that off and there's nothing there, because this side has all these vessels and this side doesn't. When I did the angiogram, you can see that that vessel just shut down. It's almost like it's absent, and it's absent. There's nothing over here. Again, there's nothing right here in this hole. It's almost like there's a hole there. What I did is I took a catheter, which is that small tube, up from the groin, all the way up into the head vessel. And you kind of move it back and forth like that. And you turn on the suction. And the vessel now is open. And so before it looked like this, whether it was shut down. After it looked like this, or it's open. And before it looked like this, where you didn't see anything, and after you can see these vessels all opening up. And believe it or not, even one small tiny vessel in the brain can cause a person to be completely weak on that side, or sometimes not even moving that one side. The other device that we have is kind of a corkscrew device called the Mercy Retriever, and we have it here. What it does is it kind of tries to lasso the clot and pull it out. And in this patient, this vessel in the back of the head was occluded. He already had a stroke in the whole back of his brain, but they figured, you know what, just try and get him open, because this specific vessel, if you occlude, you're dead. So we felt that we'd have to get this vessel open at any cost. This is where it was occluded or shut down, right here. It went up here and then just shut down. I took that corkscrew device, you can see it here, in that vessel to try and pull out the clot. And you can see that now the vessel is opened up, where before it was, this whole top part wasn't. So we got it open, but unfortunately he still had the big stroke, but he survived. The next patient is a person with atrial fibrillation. If some patients have atrial fibrillation, some patients are put on blood thinners, some patients are not. And the reason why that's important is, like I was saying, you can get a clot that originates in the heart and it gets sent up to the head vessel. The initial head CT, which is what we usually get, which is just a non-invasive way to look at the brain tissue, showed that there was an occlusion of this vessel. It's showing that there's clot here. Clot shows up as really bright, or somewhat bright, in 15% of the patients that are having a stroke. They gave him the IV TPA, which is that clot busting drug, because he got to the hospital within an hour and a half. The nurse called me up. She's like, he completely improved within 5 minutes of getting the clot busting drug. I'm like, fantastic. You don't need my services. Awesome. It worked. But then like half an hour later, she's like, he's getting worse and he's starting to throw up. So I knew that, so I was happy, of course, and then all of a sudden, he got worse, and so I rescanned him, and I got in my car. That's not my car, but I wish it was my car, but it's not. And you could see the clot looks a lot worse, and that's just because of the fact that the clot is condensing. And I looked at his head vessels with an angiogram, which is going through the groin again. And you can see that this vessel out here is shut down, and there's absence of vessels here. And what I did is I used one of the newer devices, which calls a Stent Retriever, which in this case it was a Trevo Pro. It's just there's two different brands. They both act the same. And what it is, it's chicken wire, except that chicken wire you put across the stent, or across the occlusion, in the clot. You wait 5 minutes, and what it does is it embeds itself in the clot. So it expands into the clot, in the vessel, and then you pull it out, it actually grabs the clot and yanks it out. So it's like a stent, like I did in that carotid, except you pull it out. And you're going to say, well, doesn't that damage the vessel as it's pulling out? Well, these are really soft, and they usually don't damage the vessel. But that's what his vessels look like at the end. I think I have a picture of what it looked like before, which is completely occluded and now completely open, all these vessels. He did really well. He went from a stroke scale of, I think it was 26 to 30 to 1. So he left the hospital with only a little bit of facial weakness, and that was it. So that was pretty impressive. So you can see that before the study, there's that clot sitting in this vessel here, and after the study, that same vessel doesn't have clot in it. So he did pretty well. Yeah, he went from 16 to 1. So a stroke scale, anything above 10 is pretty significant. Getting up to 20 is really bad, and 1 is essentially almost normal with 1 deficit, which was his face def. Now, just like we have occlusions in the head and the neck, we can also have occlusions or narrowing of the head and neck vessel. So I showed you a bunch of cases that were occlusions, but now I'm going to show you a couple cases that are narrowing. So the brain was getting blood supply, but just not enough. The theory is this: the shorter time that you're abnormal, the better chance of having the brain tissue get recovered. So that's why everyone tries to get all the patients to the hospital as fast as possible and to recognize the signs and symptoms of a stroke, because if you do, then you have a better chance of having a better outcome when it comes to your stroke. I mean, some patients you just can't help at all, but at least we're trying to weed out those patients. What we're trying to do is we're trying to get as many patients in the hospital that need our help, and then determine whether or not what modality or what therapy that we're going to offer to that patient. But time is the big factor. Time and actually, in addition, recognizing the fact that you can be screened and you can find an abnormality and prevent it before it happens. Last thing you want to do is be driving your mom or dad or your brother or sister to the hospital. They're throwing up. You're trying to rush. You get in an accident. You can't get them as fast. It's 911 will get to your house pretty quick, and they'll get you to the appropriate hospital, because you may not know what hospital to go to. EMS knows exactly where to send what patients at what time. That's why we're a comprehensive stroke center, and that's why we've gone to EMS, and they've said, you know what, you guys are ready to go. You guys are fully out there. The hospital administration realized that it's really good to have all the equipment that necessary as possible. The Adventist system, which owns Florida Hospital or is affiliated with Florida Hospital, they provided all the equipment necessary for us to treat all these patients, and it wasn't cheap. I mean, they're very expensive equipment, but they felt that it's very important to treat the community where they're at. So basically, that's what they've done. In other words, if your right carotid is narrowed and you're having left arm and left leg weakness, then it's usually greater than 50% that you need to treat. If you're asymptomatic and don't have any symptoms at all, usually, according to Medicare, they won't cover it unless it's 80%, and some people say if it's greater than 70%, depending on if you're in trials or not. So 70% is the magic number, 70 to 80% is the magic number for asymptomatic patients. 50% and neurologic symptoms referable to that side or that carotid are treatable.
Macular
Yeah, the eye acts that way because the vessel that supplies the eye is supplied by the carotid. So it's eye, which I didn't mention, but it's eye, and it's usually one eye. One eye, it's the same side eye, but opposite side body. So if it's your right carotid, it's left arm and left leg weakness, but right eye, and they call it amaurosis, but it's like a curtain coming down over your eye. Sort of like how you're watching TV and the station goes out and you get the fuzzy stuff. That's exactly what it's like. And sometimes it can be just that symptom. You could just have that eye and that eye alone, and that could be enough of a symptom. So, doing the carotid ultrasound studies or screenings, we'll be able to pick up those abnormalities that are, greater than,
It was so far out.
Usually if you've had a stroke originally, you're at higher risk of having a secondary stroke. But the problem is there are multiple factors associated with that. In other words, if you've had a stroke originally, yes, you're at higher risk of having a stroke in the future, but did you correct the problem that you had that caused the original stroke, or was there something that caused that original stroke? So since it's so multifactorial, it's hard to say what the odds are. I can tell you that when it comes to having a primary stroke, in other words, let's say for instance some patient had a TIA and they had carotid stenosis. The TIA or a stroke, the chance of having a stroke in the next 3 years is on the order of 30%. But if you have your carotid fixed, the chance of having a recurrent stroke after you have it fixed, the carotid, if it is significant enough, is only on the order of 9%. So you reduce that chance of having a stroke if you have carotid stenosis by threefold by fixing your carotid if it's causing your symptoms. And I'm not sure that the clinical relevance of being on a baby aspirin versus a full-strength aspirin, because a lot of studies have come out saying that it's better to be on a full-strength aspirin, but at the same time, a lot of octogenarians have other problems with bleeding and stuff like that, like ulcers or, that if you take a full-strength aspirin, you might get yourself into problems. So it's always good to, talk to your doc and say, hey, what aspirin do you think I should be on, and go from there. This lady had some weakness on the right side, light bulb on the right side of the brain. She had some narrowing involving her head vessel right here, which is high up in the brain. Being that she wasn't a surgical candidate, they asked me to use a balloon and angioplasty that. Now currently people are saying that angioplasty and stenting of the head vessels is not as good as medical therapy alone. And that's why you can say, well, why are you stenting that, Dr. Lefler? Well, the reason is because certain patients are still recalcitrant depending on how much medical therapy they get, and therefore those patients usually do better if they're recurrently symptomatic, even though they're still on maximal medical therapy, because they can have a big stroke, and if you treat them, they have less of a chance of having a stroke in the future. In fact, this specific lady, I know since I've stented her, has been completely asymptomatic. And so you can see what it looks like before, which was highly narrowed right here. And this is the vessel that actually supplies the eye. So as you guys were talking about, the ophthalmic artery, which supplies the eye and causes the carotid to cause you to have eye symptoms, this is a view of the carotid in the head, and this is what that ophthalmic artery looks like. So in the neck, if the vessel narrows down, you can see that she might not have enough blood supply to the eye. But in this lady's case, she wouldn't have eye symptoms because the narrowing is higher up than this vessel, and therefore it doesn't involve that vessel. But in her case, I went from almost about 90% narrowed to almost 100% open. And this lady, I can remember her, she was singing in church, and she had a TIA involving the right side of the brain, causing left-sided weakness. And you could see that there was this narrowing here, there was this narrowing here. And on the angiogram, which I did, here's the narrowing. It's about 70% narrowed. And then I got a small tube up there and a little balloon. There's the balloon, there's the wire up in the head vessel. And I used a balloon to open it up. And you can see what before, after, and you're going to say, well, Dr. Lefler, you really didn't improve that. What are you doing putting this patient through all this risk? I dropped her by 20%, but the worst thing that you can do is take a balloon up there and rupture this vessel, because if you rupture this vessel, she's dead. And so I dropped her from 90% narrowed, which is here, to, what does that say? Yeah, 69%. So you're going to say, well, it's not really that great, but I did some imaging after, and this color group maps show that blue is bad Red is good. So before, a lot of blue out here, after, yellow, which is down here. I'm sorry. Yellow and red, so it got a lot better in her, and she was asymptomatic since then. So less is better sometimes, but as long as you get better flow, it looks a lot better. And this last case is a case where it's a hemorrhagic stroke. So remember I talked about ischemic stroke, not getting enough blood supply to the brain, and hemorrhagic stroke where there's like something that has ruptured inside the brain and it needs to be fixed. This is a CT scan, and basically all this white stuff, white is bad in the brain, is blood. So there's blood everywhere in his brain, surrounding his brain, not in his brain, but surrounding his brain. And he had this small little Mickey Mouse aneurysm with the two ears pointing at you of this carotid artery, which is the vessel in the head. And what we had to do is we had to put a bunch of coils inside the aneurysm to shut the aneurysm down so it wouldn't rebleed in the future. And at the end of the case, you can see the coils. The aneurysm isn't filling, and he did well. We do see these vessels. These are the big trunk. The vessels of the head are like a tree. So it starts off like a big trunk, and as it goes up, it sends all these branches out, and on each of those branches it has smaller ones, and then on each of those little smaller ones it has smaller ones. So what we're seeing from an imaging standpoint, even from an angiogram standpoint, is you sometimes don't see the little vessels, tiny vessels, and sometimes those vessels can occlude and cause a stroke, but we just don't see them. And usually that's from hypertension, smoking, diabetes, stuff like that. Basically, it was from a vascular malformation that was an abnormal tangle of vessels behind your ear that needed to be fixed. And that is one of the causes of it. It's not the most common cause. And what I was asked to do is do an angiogram, and you can see that, I know you guys don't know anatomy, but basically there's a bunch of abnormal vessels heading up here into this structure right here. And, I was asked to put a bunch of coils in it to shut it down, and so this is before all these vessels heading out here, and this is after that there's no vessels. So this caused tinnitus, but there are multiple causes of tinnitus. Some are medical, some are inner ear problems, some are vascular, some are not. You can be on the vein side where there's a vein, veins are the structures or the vessels that drain your brain. So arteries go up to the head, and these are all I showed is usually pictures of the arteries where the vessels are going to the head, but there are also vessels that come down from the head back into the heart. Because remember, as the body supplies the brain with blood, it has to actually also drain it. So veins behind the ear, as they narrow down sometime, can also cause tinnitus because as the blood goes past it, as it constricts, you hear, it's like a hose. If you have a water hose with a gun on it, you know, the more when you open up that gun, you can hear the squirting of the water, same thing as the vessel narrows down, versus having an open hose that you turn on, it really doesn't make that much noise. Yeah, sometimes it's just inner ear problems that, you know, you can go to an ENT doc and see what they say. Basically, the thing about tinnitus is you want to make sure it's not a treatable cause of tinnitus. Because if it's not treatable, then you just assume it's there, but if it's a treatable cause, then you may need to treat it.